speaker, Dr. Craig Riley, who did his medical school training at OHSU, did 3 years of residency here at Providence, Portland, and then did a chief year from 2013 to 2014. He continues on as faculty here in medical education, which we are greatly appreciative of. He's really wonderful to work with. And he also is quite busy serving as the Associate Medical Director at Primary Care up at the Vancouver Clinic, so a very busy fella. Today he's going to be talking to us about marijuana for the clinician. Thank you, Craig.
Thank you. Good morning. Can everybody hear me okay? Sounds like the mic turned on. So I've been asked to do this talk around the region, I think in recent times in large part because of the interest in marijuana, and I think that there's a lot of misinformation out there about what marijuana can do, what kind of evidence we have for symptomatic benefit, as well as misinformation about how it may be harmful. And so I'm hopeful to provide a little bit of an evidence base for that today and give you some guidance in terms of how we might counsel our patients, specifically taking a good history for them and understanding the factors that really matter as we decide to give them advice. I know that Oregon is especially interested in marijuana right now from a legislative perspective, and I'll talk about that a little bit as well, and hopefully give you guys some guidance to work with your patients moving forward. So my objectives today are to provide a little bit of the basic language, I think a lot of which is familiar to most of us already, discuss some of the side effects from an organ-based perspective, and then talk a little bit about what limited evidence we have in terms of symptomatic benefit, and the ultimate goal being to learn how to take a good marijuana history. So this is a case I'd like to start with. This is a 55-year-old woman who comes in to establish care. Her past medical history, interestingly, is notable for an acute MI at the age of 37 with clean coronaries at that time. She struggles with frequent ER visits for acute episodes of abdominal pain and has been admitted for this twice with 14 abdominal CTs in the past 2 years. This is, as a hospitalist, not an uncommon presentation, unfortunately. She also has a recurring productive cough, worse in the winter months. Her principal complaint today is about depression and being frustrated with doctors because they never seem to know how to help her. She denies any illicit substance use and is hoping you'll sign her medical marijuana card today. Her exam is normal, and ultimately, the question here is, how do we take a good history? How do we know which pieces of her history correlate with her marijuana use or may be directly impacted by that? And how do we counsel her moving forward? So my hope with this slide is just to provide a little bit of brief understanding of the endogenous cannabinoid system. So we know, based on a lot of animal models and some autopsy models, where the cannabinoid receptors are located throughout the body. We have some understanding of the CB1 receptors that are concentrated primarily in the CNS, and those bind THC more tightly than some of the other chemical compounds that are found in most marijuana preparations. CB2 receptors are found more throughout the GI tract and throughout the periphery, and they bind cannabinol a little bit more tightly. Cannabidiol, which is a very popular target for therapeutic development currently, binds to each receptor with varying affinity. So what we do know about the system, the endogenous system, is that it's a negative feedback loop. We have endogenous cannabinoids present, anandamide and 2-AG are the predominant ones. They, when agonized more frequently, can promote weight gain, hyperlipidemia, lipogenesis, insulin resistance. So interfering with this process through an exogenous pathway can have those kinds of effects. We have a hard time studying marijuana simply because there's so many different concentrations of these compounds throughout the different samples. And so trying to focus in animal models on what each version does with each set of receptors has been really the focus of research thus far. And then we also have the challenge that there can be very opposing effects accomplished by these different compounds. So THC can be more psychoactive, cannabidiol can be more anxiolytic and antipsychotic. So we're still learning a lot about that, but that's sort of the basis for the physiology for marijuana in our system. When it comes to consumption, there are basically two types of sort of marketing strategies. There's the plant-based version, so Sativa is marketed for the mind, and indica is marketed more for the body, again, because of the different concentrations of the different compounds found in those plants and how they affect those different receptors distributed throughout the body. Some of the language that I think we should all be familiar with, so leaves, stems, and tops in pipes, and cigarettes is known as a joint. Tobacco leaf wrapper from a cigar is what's known as a blunt. Hashish is resin or exudate from the underside of the leaves that can be smoked in a tobacco mixture in a very, and can also be distilled into a potent oil. Sensimilla is from the sativa flower, and that can be a very potent preparation, taking it from the flower. And then there's, of course, the hookah, pipe, bong, e-cigarette, and vaporizer, and we'll cover those in more detail. Hotboxing, the first few times I gave this presentation, I had people come up to me afterwards and ask me what this is, so I'm going to explain it. It's basically the use of marijuana in a small confined space, smoked, so that it creates a high concentration in the air, usually accomplished in a car. So there are a variety of ways, obviously, that people use marijuana, and there can be very creative ways. It can be very dangerous. One of those is boosting, so adding tobacco or other drugs to marijuana. And then there's dabbing, which is basically a preparation of butane hash oil, which is highly concentrated. To get there, it's a very combustible process. So there have been lots of reports of explosions in homes where people are trying to do this on their own. And then when they do prepare the butane hash oil, they usually smoke it by essentially freebasing it, meaning that they put it in a spoon and heat it up and inhale it in that way. So obviously another creative way that people have found to use marijuana that can be very dangerous, especially if they're trying to prepare it on their own. And then finally, maybe the most toxic thing that anybody can do to their body is what's called sherms, where they take a joint, dip it in PCP, dissolve it in formaldehyde, dry it, and then smoke it, which is hopefully nothing our patients are doing, but that's a term you should be familiar with as well. And then, of course, there are edibles. So edibles can be challenging. They're legal in Oregon as of June 1st, so that's relatively recent legislation that has made the way we think about edibles much different than previously. It's been legal in Washington for quite a while, and when Colorado went to legalize, they proposed legislation recently to actually ban the edible marketing and the use of edibles, except for the liquids and lozenges, which have more therapeutic purposes. And a lot of the reason is because it's very difficult to know what kind of concentration is in the edibles, and it's very difficult to get patients to use them appropriately. So the therapeutic dose, for example, in a marijuana cookie may be a quarter of a cookie. But the problem is people like to eat a whole cookie, first of all. And second of all, when people are used to inhaling marijuana or ingesting it in another high concentration, potent manner, the effect is usually immediate. So when they ingest it, it's not immediate, and they think it hasn't worked, so they take more. So the end result is more and more unintentional overdoses, and especially in children. So this is an example of marijuana-infused gummy bears next to normal gummy bears, and frankly, you couldn't tell the difference by looking at it, right? So the problem is it's difficult to tell, and it also leads to some sort of unintentional marketing to children. And so you end up with unintentional overdoses in adults, but especially in the pediatric population. That makes the dosing challenging. And then also because marijuana is still considered a Schedule I drug, even after this was reevaluated this summer, in August, they came down and said marijuana is still considered a Schedule I drug. They were able to adjust the legislation a little bit to allow for more marijuana samples to be used for research purposes. But because it's still Schedule I, the FDA can't regulate it. And that makes it even more challenging for us to know dosing, research, et cetera, exactly what to do with it. Other cannabinoids that I think are important to know about, I've certainly seen some of these in the inpatient setting. Dronabinol has been FDA approved for antiemetic use. It is Schedule III. It's important to know it's contraindicated in those individuals with schizophrenia because of the concern about the correlation there between those types of psychiatric disorders. Nabilone is Schedule II, FDA approved for nausea and vomiting from cancer chemotherapy, and is being used more and more frequently now. Nabiximols is approved only in Canada, and that's approved for cancer pain, spasticity, and MS-related pain. And then it's important, I think, to have some awareness of the synthetic cannabinoids, which are becoming more and more popular on the street, and that includes K2 or Spice, are usually the way those are referred to. they tend to have a higher potency than other marijuana formulations. So switching gears a little bit, just a few numbers that I think are important for us to be aware of living in Oregon, and I've actually got a few from Washington as well. There are 147 recreational dispensaries as of the end of June. Medical marijuana dispensaries can also sell recreationally until December 31st, when there's expected to be more legislation guiding that. That hasn't been defined yet, but the expectation is that there will be more of a collapsing of the two different policies for medical marijuana and recreational marijuana, much as like what Washington has done. There's been $25 million in taxes collected from the sales of recreational marijuana up through the end of July 30th. Now that's interesting in the sense that Oregon projected for all of 2016 that they would collect somewhere around $8 million. So in the first half of the year, they've already collected more than 3 times that. And the projection is now that they're going to collect somewhere between $35 to $40 million this year. So obviously, legalized marijuana is unlikely to go away in Oregon. The average price per gram on the recreational market, and this is taxed, so recreational marijuana is taxed, medical marijuana is not, is $13 versus $10. The recreational and medical policies in Washington have been condensed and merged together as of July of this year. So the average price per gram in Washington compared to medical marijuana in Oregon is almost $4 per gram more, which is why you're seeing a lot of the dispensaries up in Washington just across the river close down, and you're seeing a lot of patients come down here to get their medical marijuana. I saw just driving in a number of new billboards and shops that I'd never seen before with lots of very green advertising. I saw a billboard for something called Weed Maps, which sounds like a really, really useful app for somebody who wants to find doctors who are going to prescribe medical marijuana, dispensaries, and pretty much anything else they might need. Girl Scout cookies is the strain that is the best-selling strain, according to the Oregonian, as of June. And incidentally, Girl Scout cookies themselves also sell very well in Oregon. There's a correlation there for sure. 1 in 10 adults in Oregon used marijuana before legalization, so obviously the assumption is that that number is higher now. And it's also, I think, interesting that there are still a number of cities and counties in Oregon that have been able to opt out of allowing licensed marijuana businesses. Oregon has also been somewhat unique in reducing penalties for marijuana-related offenses and having people with prior convictions have those set aside. Washington and Alaska have been slow to adopt these kinds of policies, and it's still a felony to possess 20 grams in Florida. So there are some specific things to be aware of also in Oregon with respect to this. Washington has actually had medical marijuana allowed since 1998 and then legalized recreational in 2012. Again, it's more expensive in Washington, and there's a database in Washington that's unique. So we don't have that in Oregon. If people are willing to sign up for the database, then they are able to be exempt from sales tax. Unfortunately, there have been breaches of personal information, but this allows them to be able to have and grow more medical marijuana if they do sign up for the database. If they have provider approval, and provider under Washington legislation includes an MD, DO, NP, or PA, they can again have and grow more. This is the exact list in the Washington legislature of what qualifies for a medical marijuana patient. In Oregon, the list is actually a little bit shorter, although it includes a couple other things. So Oregon, the list is basically cancer, HIV, glaucoma, seizure disorder, so epilepsy, PTSD, and then also Alzheimer's related conditions is an approved condition in the state of Oregon for medical marijuana. What's interesting about the marijuana legislature in Oregon compared to Washington is there's a complete other additional list in Oregon here that includes any medical condition that results in severe pain, severe nausea, or a variety of other factors. So there is a much broader umbrella under which you can catch someone and state a test, essentially, that they qualify for medical marijuana in Oregon than in Washington. So again, I do think we're going to see this is even more important here than it has been in Washington. The state of the evidence currently is that we're developing more well-done prospective data, but the data is still very limited. The most data and the most reliable data we have is around intracellular signaling in animal models. The confounders, again, the federal restrictions in terms of August that legislation allowing more research, but still not as much as we would like. And still it being Schedule I makes it difficult for the FDA to be able to regulate it. Most patients who use marijuana also use some other concomitant substance, whether that be tobacco independently or boosted as part of the content that they use in marijuana, concomitant illicit use, other factors. And then there's also been this escalating cannabinoid concentration in recreational marijuana preparations. So this comes from the New England Journal in 2014. And over time, you can see that there's been quite an increase in potency, suggesting that the comparison of studies from current day to quite a long time ago makes it very difficult. So this is sort of the bulk of what I'm going to talk about today, and it's the kind of evidence-based physiologic awareness and knowledge we have about the adverse effects of marijuana, specifically with respect to a few organ systems. So we'll start with neuropsychiatric. There's actually pretty good data that addiction is a component of marijuana use. That's been controversial in the past, but there's decent epidemiologic and physiologic data to support that. There's the concern that especially in adolescence, there's the consequence of altered brain development, leading to cognitive impairment and adverse socioeconomic outcomes. There's also an increased risk, or at least a correlation, with the earlier development of chronic psychotic disorders. All of these issues are more strongly associated with initial marijuana use early in adolescence. So it's really that patient who used early in adolescence and used frequently that you're more concerned about the neurocognitive effects. In terms of brain development, there's active brain development during adolescence in the endocannabinoid system itself. So we know that the endocannabinoid system, which is highly concentrated in the CNS, is developing during adolescence. So interfering with that with exogenous marijuana is likely to interfere with that development. There's, in autopsy studies, been found to be actually fewer brain fibers in specific brain regions like the precuneus, which is important for self-awareness, and the fimbria, which is important for learning and memory. So you can see why there's thought to be a clear correlation there between early marijuana use, especially in adolescence, and the ultimate consequences socioeconomically. Additionally, some sobering facts when we think about the adolescent population and we think about the long-term effects of that. 12% of people aged 12 or less have experimented in the past year. This also comes from the New England Journal. And that essentially means that of that age group, almost 1 out of 10 has, or more than 1 out of 10 has experimented. That's a very young population to be exposed to something like this. And then when they survey 12th graders, so 17 and 18-year-olds, and this doesn't even include the dropouts, this is just people in school, more than 1 out of 20 are using daily. So daily use is really correlated with these neurocognitive side effects. And we're talking about people who are in school, planning to go to college. So certainly the effects of this can be significant. This is just one example of the kinds of studies that have been done to look at the effect on cognitive impairment. Again, the human studies to do this have been very limited. So this took smokers and compared them to non-smokers and did a processing speed task. So an analysis of a figure or some other task that required them to do processing. They were significantly slowed if they were chronic marijuana smokers. Those who were non-smokers were considered the baseline. And then they had them smoke their usual amounts over about a 30-minute period and reanalyze their processing speed, and it normalized in those patients who were chronic smokers. So this lends credence to all those friends you had in high school who said they had to get high before they took their SAT. They were right about that. So this deficit develops with chronic smoking and actually can normalize with acute intoxication. This was a well-done 2011 review that looked at the effects over acute intoxication, subacute residual effects, and long-term effects with respect to a number of cognitive processing type issues. So they found with attention and concentration, acute intoxication got worse with abstinence and improved with use, consistent with the prior study. And then they saw no effect long-term. Decision-making had latency and response speed delayed, and then that improved with abstinence time. And then as you go through these, you can see that there is clearly some effect acutely that improves with some subacute cessation, and then with long-term cessation, a lot of these things are reversible. The caveat to this is that it's still thought that the adolescent population, especially those daily users in adolescence, are more likely to have long-term neurocognitive consequences. Just an anecdotal example, back in 1994, it was a big deal to use 14 censored language episodes on a talk show like this. And clearly, I think you can tell Dave is not very happy with what's going on here. But Madonna said later it was because she smoked a joint and wasn't thinking clearly. And now we have evidence to support that. So, when it comes to motor vehicle accidents, there's actually good data suggesting that there's substantial driving impairments. I was interested to see that for those who have a blood alcohol level above the legal limits, you're actually even 5 times more likely to be involved in an accident if you're using marijuana. And these were in controlled simulation studies. And then there's a dose-dependent effect. So at higher THC levels, you're even more likely to be involved in a motor vehicle accident. So assessing this as part of our history when we talk to our patients is important. With respect to psychiatric disorders, regular use is associated with increased risk of anxiety and depression, but of course it's really difficult to establish causality either for anxiety and depression or for these chronic psychotic disorders. But there has been thought to be an earlier onset in the psychotic disorders for those who are heavy users in adolescence. So moving on, the cardiovascular effects are limited. Obviously, we don't have very many human studies. In fact, this is really the only human study we have to work from. This was in 1972 when we looked at marijuana smoking. And this started with, very interestingly, 10 healthy volunteer doctors in London. So you already get the joke, yeah. Engaging in an activity that fortuitously presented itself during a recent trip to Asia. So those fortuitous trips to other countries were what got in the New England Journal in 1972. They measured limb blood flow by venous occlusion plethysmography and then measured vital signs and rectosigmoid temperature. I don't want to comment on that, but this was an interesting study. So they basically did, during and after a 3-minute period of smoking a marijuana cigarette, they measured these factors, and then they also did a couple of tasks. They found that mean heart rate increased, blood pressure increased slightly but quickly reversed, respiratory rate and temperature did not change, and then blood flow increased proportionally as you would expect with the increase in heart rate. But interestingly, only to the larger vessels, not to the smaller vessels of the hands and feet. This was their figure 1, the only really dominant figure in the study. So this essentially is their results during this fortuitous exercise. So we have blood flow on the y-axis, time on the x-axis, and then this was before smoking, so they had a task. Task A was a cognitive task. So blood flow to the periphery decreased during that cognitive task. B was putting one of the opposing limbs in a ice-cold vat of water. So they were exposing another limb to ice-cold water, ultimately resulting again in decreased blood flow to the periphery. Then they smoked marijuana, repeated the tasks, and there was no change, suggesting that essentially they didn't care about the ice-cold water or the neurocognitive task after they smoked the marijuana. So the ultimate conclusion here was there may be something that takes place in the microcirculation or in the circulation of the small vessels that is interesting. And they derived that largely, again, from looking at their blood flow measurements. And this is relevant when it comes to acute MI. So there actually is epidemiologically seen atypical MI presentations in a younger population without coronary disease in marijuana users. There's also a temporal relationship that's somewhat interesting here where you have a 5-fold higher risk of developing MI in the hour following marijuana use. And that correlation has been also seen in these case reports of stroke. So the concern there is that there may be some effect in the microcirculation that is leading to this. There's also been found to be increased mortality, at least in a retrospective study, in marijuana users versus non-users who have acute MI in the hospital. The mechanism here is thought to be, again, because of a deleterious effect on the microcirculation. So essentially coronary blood flow may be compromised by the marijuana use in direct reflection from the cannabinoid exposure. The myocardial oxygen demand increase is likely also to contribute, and then you should expect to see this more in patients with coronary disease, but because of the high concentration, the high use in the younger population, it's not unusual for us to see an acute MI in that population that's using marijuana. Unfortunately, the human study we have is that terrible study from 1972. In the vasculature, in terms of animal models, we've seen that there's a vasorelaxation, but also a vasoconstrictive response. initially hypertension and then orthostatic hypotension. So the bottom line is it's really complicated, and we don't know exactly what happens in terms of the vasculature. We do know that there are cannabinoid receptors throughout the vasculature, and moving forward with human studies would help us quite a bit. In hypertension and cirrhosis, they actually see the vascular responses are enhanced, and they're blunted in obesity and diabetes. And there's thought to be some component of obesity, again, going back to what we know about how cannabinoid receptors are distributed in the body and the effects of using those receptors, that correlates here. There's also been case reports of sudden death, strokes, and a number of other conditions, but it's difficult to really know what to make of these because we have such few numbers of these. They've also seen MRA findings of arterial constriction in that hour after marijuana, suggesting again that there's a direct vasoconstrictive response. And there's also been thought to be some kind of a predilection for the basal ganglia in the strokes that have been reported. So moving on to the pulmonary system, when it comes to thinking about the adverse effects of your pulmonary system, it's largely dependent on the method of use. And I'll touch on this more at the end of the talk, but it's really important to understand how do you use the marijuana, because that really is going to affect what kind of side effects they might expect. When it comes to pulmonary mechanics, they see forced vital capacity actually improves. And the thought there is just that these patients are so used to taking such deep breaths that they're really good at forced vital capacity. There's also thought to be an association with a reduction in FEV1 in heavy prolonged users. But when they've looked at that more carefully, and this speaks specifically to the analysis for lung cancer, a study where they looked at joint years, this was an epidemiologic study looking at increased incidence. They saw increased incidence, just like they saw reduced FEV1 in patients who were chronic users, but the association disappears entirely when they correct for tobacco use. So that piece of helping our patients quit smoking tobacco and understanding how much of what they use includes tobacco or whether they use tobacco separately is a really important point for us to get across, part in our counseling about tobacco cessation, but also in terms of our thinking about their risks moving forward. So the thought here is really that there's not a direct cannabinoid-based mechanism by which lung cancer increases. In fact, it may not for using marijuana alone. Chronic bronchitis, however, is a little bit different. So we've got increased mucus production, and this has been demonstrated in a number of animal models. So there's goblet cell hyperplasia that takes place. There's also impaired mucociliary clearance. And then we know that there are cannabinoid receptors on macrophages that can lead to impaired phagocytosis, increased apoptosis, and you can imagine that that's likely how you end up with these chronic bronchitis symptoms. So you've got an inflammatory process driving the inflammation cascade into the airways, and then you've got impaired clearance, you've got non-functional or less functional macrophages, and that leads to a bunch of junk in the airways, leading to that cough and those other chronic bronchitis symptoms. Vaporizing has been a really popular subject. Anybody who's talked to a patient who uses marijuana recently has probably heard the argument that it's safer because I vaporize. And the theory here is that it's not hot enough to release those toxins that come from combustion, but it is hot enough to release the cannabinoids. The only study, unfortunately, that we have to look at this is this internet study from 2007 where they basically went to Facebook and asked for symptoms and then correlated those with patients' marijuana use. So it's a large number of people, but they're Facebook people, so it's tough to know what to do with that. Vaporizer use predicted fewer symptoms, and for larger amounts of cannabis, the difference in terms of those who used vaporizer and those who used other methods of inhalation was bigger, suggesting a dose-dependent response. So I haven't gone as far as to say, yes, you're right, use of vaporizer is a safer method for inhaling cannabis, but it has led me to think of all the methods, if we have to choose one, this might be the safest. But it's a common subject that I think a lot of people are bringing up now, especially because of the wealth of information that's available on the internet. Moving on to GI side effects. So we know that the cannabinoid receptors are distributed pretty consistently throughout the GI tract. With respect to the CB1 receptors, those are found in the lower esophageal sphincter, throughout the gastric body, as well as throughout the GI tract itself. The ultimate consequence there is decreased gastric acid secretion, decreased gastric emptying, and ultimately decreased intestinal motility, secretion, etc. There's also an inflammatory effect in the CB2 receptors where you have decreased inflammation throughout the GI tract. So knowing that those are there certainly leads to what we expect to see clinically. With respect to the hepatic system, normally there actually aren't that many CB1 or CB2 receptors in the liver. But with marijuana use, those receptors get upregulated. And that can lead to more expression in progressive liver disease especially. So there's a pro-fibrogenic, pro-inflammatory effect on CB1 receptors, which are found in higher concentration throughout the liver. CB2 receptor agonization actually can reverse liver fibrogenesis. The overall effect is thought to be progression of liver fibrosis and steatosis. In end-stage liver disease, which is certainly a population that we see frequently here in the hospital, an end-stage liver disease population that uses marijuana, you can see a higher frequency of hepatic encephalopathy. So for those patients who come back time and time again with difficult to manage hepatic encephalopathy, asking about marijuana use is important. You also see more portal hypertension and more peripheral hypotension. Cannabinoid hyperemesis syndrome is something that I think everybody should be aware of. Most of the hospitalists in the room are going to be very familiar with this presentation. They probably see a patient with a similar presentation on almost a daily basis here. And this is usually a patient who presents almost in a cyclic vomiting type presentation. So it's usually recurrent, grippy, crampy abdominal pain, comes with nausea and vomiting, but the pain is the thing that they report the most. The kind of pathognomonic finding here, and the thing to really ask your patients about, is that it's temporarily relieved with very hot showers or baths. So it's very common for you to see patients report, things get better when I take a hot bath or a hot shower. When they looked at this, the prevalence of that was actually somewhere around 50%, but of those patients who reported taking hot baths, about 90% of them reported that it was relieving of their symptoms. And the hypothesis for the mechanism here is that there's a dysregulation that takes place with marijuana use in the hypothalamus, and the hot baths correct that thermoregulatory dysregulation. So we also see dehydration quite commonly, and we see it often in young individuals with chronic use who use it at least weekly. Initially, when this was reported out of Australia back in the early 2000s, the thought was that you needed to be a chronic user, someone who's used marijuana for 5, 10, even longer number of years. We've seen more and more that it can happen with people who have not used it for very long, even 6 months to a year, and only use it weekly. The case of this that I saw as an intern here at Providence, Portland, was very striking. It was a patient who came in mid-20s, very young, who presented with remarkable dehydration. So his creatinine was 4.5, his calcium was 14, he had dramatic electrolyte abnormalities, and we spent the first few hours of his admission repeating his metabolic panel, trying to understand what was going on. With hydration, we found things correct very quickly. But over those first few hours, we quickly realized that he was still having the pain and he was still struggling with his symptoms, meaning those electrolyte abnormalities and all the other factors were not what was causing his symptoms. So the underlying cause ultimately was found to be this cannabinoid hyperemesis syndrome, and we made the diagnosis because at one point he came running out of his room, yelling at people down the hall, begging them for a shower, because there was no shower in his hospital room. And so our psychiatrist liaison service actually picked up on that and pointed us in the direction of these cannabinoid hyperemesis presentations. So that's usually the pathognomonic finding, but it's also important to note that there are a lot of patients who use marijuana who have this syndrome who don't actually report the hot bath correlation. There was criteria that came out in 2012. This came out of Mayo. They looked at 98 patients and identified things that were essential, as well as major features and supportive features. They found a morning predominance of symptoms was a supportive feature, which was interesting, as well as actually normal bowel habits is supportive, as well as a negative workup, essentially. Most people report, or most cases report daily use. However, weekly use is usually enough. Acute episodes resolve usually in 24 to 48 hours, but you need patients to stop for at least 3 months to stop seeing the cyclic presentation of the abdominal pain, nausea, and vomiting. And that becomes really challenging because people so often associate cannabis use with improvement in terms of nausea, vomiting, and abdominal pain. In terms of symptomatic benefit, it's really important for us to be aware that there's unfortunately not the data that we would hope for to support this. So in terms of glaucoma, we do see a transient decrease in intraocular pressure, but there are other treatments that are more effective, and so using it for that purpose has been phased out quite a bit. Nausea, in that case, it's thought to be an effective antiemetic and an effective suppressive agent for chemo. But again, there are other things that we can use that can be more effective. I was a little disappointed to find that there's actually mixed data on AIDS wasting syndrome in terms of weight gain. As you might expect, the mood and quality of life improve significantly. So we do see, especially some of these more therapeutic preparations of cannabis used more often in that syndrome, and especially for any cachectic picture. So that's also one of the conditions that's captured under Oregon legislation as qualifying, as a qualifying condition. In terms of anti-inflammatory benefit, we know that there's the effects on the macrophages, and there's the effect that you would expect in terms of reducing the efficacy of those macrophages, leading to an anti-inflammatory effect. So there's some promising initial animal studies in rheumatoid arthritis and inflammatory bowel disease. The best data that we have for this in terms of being efficacious for pain is in MS and in central pain. So those patients who have spasticity-related pain tend to see the most benefit from cannabis. And usually that's oral cannabis extract, at least in the studies that's been looked at. I was also disappointed to find in epilepsy there's actually not very good data. It's thought to be mostly ineffective in that situation. I certainly have had my fair share of epilepsy patients who come in and feel like it's very effective, and they use high concentrations and high doses on a regular basis and feel that it helps things keep their seizures at bay. The data doesn't support that. And then when it comes to chronic pain, which is probably the population where we see the most of this, it's been found to be effective for neuropathic pain, but not really effective, at least reliably, for other types of chronic pain. And that's important because there is a population that's going to come to you and ask for your thoughts on medical marijuana with respect to chronic pain. And that is captured in the Oregon legislature as one of those conditions that's appropriate for medical marijuana. But the studies that have looked at this have only found support specifically in neuropathic pain. So the best study that looked at this was from 2013, coming out of the Journal of Pain. They looked at placebo versus two different concentrations of vaporized cannabis. So again, presuming vaporized cannabis was safer, they were able to do this study. The number needed to treat for their thresholds to qualify as a primary endpoint for pain reduction was a 30% pain reduction. And when they compared that to placebo, they found for the medium dose THC it was 2.9, for the low dose 3.2. Medium versus low dose, there was no significant difference, suggesting that there was a pretty legitimate number needed to treat associated with any marijuana use for those patients with neuropathic pain. And this was comparable to studies that looked at gabapentin with respect, at least, to number needed to treat. So going back to our case and thinking about the effects of marijuana that may be contributing to her presentation. So we know that when it comes to these clean coronary MIs, marijuana can be one of the contributors. We see that pretty often in the hospital. It's important to keep that in your differential. So that's probably associated with marijuana use, and her depression is probably associated with marijuana use, although again, we don't have good causation data to necessarily say that for sure. When it comes to some of her other symptoms, specifically her acute episodes of nausea and vomiting that led to all those abdominal CTs, it's probably a component of cannabinoid hyperemesis syndrome. Her recurring productive cough, based on those effects in the airways, especially the anti-inflammatory effects, is probably directly related to the marijuana use, agonizing those receptors. And then, of course, the next question becomes, how do we take an effective history and counsel her about her marijuana use? So I think it's important to ask at what age you started. For patients who use during adolescence, whether they were daily, weekly, or less frequently using also matters. Again, the neurocognitive effects are thought to be more correlated with those patients who use it frequently and who use it in adolescence, especially if they're daily users. How often do you use currently could certainly give you the information you need about what the effects may be on their symptoms long term. And then the method, of course, matters quite a bit. So especially with respect to the pulmonary conditions, the toxicity is directly related to the method. When it comes to blunts, joints, and hookah, it's important to know that there's a lot of high temperature combustion and the toxicity that can emanate from that, as well as the tobacco content can be very high in those methods of use. Glass pipes come with a dangerous resin inhalation, which can be independently toxic to the pulmonary system. Hookah itself, again, has the combustion product issue. Dabbing, again, with respect to the butane and the butane hash oil, can be very volatile and very dangerous. And then vaporizing, as far as we know right now, is probably the safest method, but I certainly would not go as far as to say it's safe. And then with respect to edibles, thinking about content and potency, that can be very unpredictable. I think it's also important to do a quick screen, a quick review of systems, thinking about the different systems that can be affected by marijuana use. So depression or anxiety, using your typical screening tools, thinking about long-lasting symptoms of chronic bronchitis, any symptoms that could correlate with cannabinoid hyperemesis syndrome, because that gives you a clear trigger to counsel them for cessation. In fact, I've been pretty impressed in the patients I have seen and in other providers I've talked to who have counseled patients around the lines of, this is what's causing your abdominal pain, nausea, and vomiting. The cessation results are a little bit more impressive than you might expect. Chest pain, especially in the first hour after using, could be suggestive of that microcirculatory effect in the coronary vasculature. And then also thinking about the neurocognitive effects, memory loss, difficulty concentrating on tasks. So that will ultimately guide what kind of counseling you want to provide. Also thinking about withdrawal symptoms and addiction pieces could be really important to decide whether or not to refer for substance abuse counseling. So for patients who go 3 days without using, you would expect to see some withdrawal symptoms, irritability, anxiety, craving, those kinds of things. Certainly assessing their motor vehicle accident risk is important. And then also thinking about illicit substances and, of course, tobacco counseling, knowing that there's a lot of correlation there between use of those substances. Think about referring for substance abuse counseling if patients are motivated to quit, if there's evidence of addiction in their behavior, if they have multiple substance use, or if there's any of these other conditions that you're concerned about. So that's what I have today. I know that this is a topical subject, and I know there's probably a lot of questions around this, and I'd like to answer whatever I can to help with that. So thank you very much. Please, go ahead. Yeah.
Slides.
Sure.
I know it's on certification marijuana, but if you think dabbing, you didn't understand. What about dabbing, blunts?
Yeah.
You okay? Can you explain this stuff?
Well, yeah, so the question is, what about dabbing and blunts? I think it's probably right here. So we talked about this in the beginning. You may have missed that first few minutes where we covered this. So dabbing essentially is the process of infusing content into the marijuana that can lead to very toxic and very explosive events in the home. And it's also the process that leads to a highly concentrated hash oil that a lot of patients freebase, meaning they put it in a spoon, they heat it up, and they inhale it. So that's typically the process there. A blunt is a tobacco leaf wrapper that includes marijuana, sometimes tobacco and other pieces there. So that's that explanation. Yeah. Yeah.
Did you find any information on like severely immunocompromised and like invasive fungal infections with inhalation of marijuana?
So from our infectious disease colleagues, any thought about immunocompromisation and thinking about exactly what the effects of marijuana might be in a patient who's immunocompromised? I didn't come across that. Certainly there's the physiologic basis to explain that, to think that there may be an effect there, especially knowing what we know about patients with RA and IBD and some of the initial studies there. I'm interested in your thoughts about that in terms of what you've seen.
Full-on neutropenic patients, like bone marrow transplant patients and acute leukes that have prolonged periods of neutropenia. I think a lot of our colleagues have probably seen invasive lung infections with fungus, so probably contamination of the marijuana that's inhaled. So it's something that I counsel patients that are chronic users to be wary if they're going to be severely immunocompromised.
Great point. So those patients who are chronically immunocompromised, thinking about the contaminants, including the fungal pieces there that could lead to a chronic fungal infection, and counseling them and letting them know that their risk is probably a little bit higher if they're a regular marijuana user with that. Great. Yeah.
So that was great. I mean, I think from a pulmonary standpoint, I certainly have a lot of asthma patients in particular. It's on the internet that this is a good treatment for your asthma.
Yeah, that's great, right?
The problem is, and a couple of my partners have had some comments about this, you can't really forcefully say, boy, that's wrong, just because the data is all over the place.
Right.
I think one of the advantages of the Oregon and Washington legalized is previously, there's no quality control in street drug use.
Right.
So that was part of the problem. They're smoking marijuana, but who knows what else they're smoking?
Right.
Now at least we know they're just getting marijuana, and it'll be interesting to see what it does to people. We don't really know. My only comment about vaping is there are some folks I know at Hopkins in particular, I've seen a presentation on a study. There's concerns about the battery and the heating element actually
Yes.
releases ozone and other elements beyond marijuana. So it's actually probably going to be worse than even just straight smoking marijuana.
Right.
Just because of those different elements. But as I'm sure you've seen, or folks hear a lot of the electronic cigarettes help you
Yes.
stop smoking, and it's better. And vaporizing is a big one for marijuana that in asthma that it doesn't cause any problems. But it's kind of tricky to counsel people because if you immediately shut it down, they look on the web and they understand that you don't really have a whole lot of data. So
Yeah.
it's kind of hard to counsel people right now.
Right.
Generally sounds like a bad idea to put that in your lungs.
Yeah.
But I don't get too definitive about it.
Right.
It's a bit difficult.
I think those are all really good points. So thinking about patients who come in just in general with this internet base of knowledge and trying to argue with you is going to make it a very difficult therapeutic interaction, right? So that applies to really every method of use, and it applies to all kinds of patients and what they're trying to treat with their marijuana. With respect to asthma, so it sounds like it makes asthma worse in general. I mean, you would imagine that given what you know about the tobacco and other content in a lot of the preparations.
Certainly,
Right.
there's already an issue in asthmatics bring up a lot of mucus. I would presume it does that, but whether it causes bronchoconstriction or bronchodilation, I
Right.
think we just don't know.
We don't know yet, right?
People swear it helps. I have people who smoke it in an acute attack.
Interesting.
I don't think that's very good.
Right. Right. And then I think the other point is really important about being aware that there are other pieces to the e-cigarettes and the vaporizers that can be really, really toxic. Yeah, Ruben.
So I think at this point in history, we're actually asking the wrong question. I think the data is, there's associations with some harms, there's associations with some benefits, but the real question is, does marijuana pose such a threat that we really should create a society where it's illegal and we arrest people and have this whole legal structure? And I think the preponderance of evidence would suggest no.
No, right.
Like, I think you can make the same arguments about lots of things that are illegal, and, people aren't doing randomized controlled trials on alcohol, even though there's clearly medical benefits. So I think we have to be careful, because our patients' experience is, for a lot of them, they smoke some, since it's been legal, and they don't see the negative effects that get reported.
Right.
And so it starts to take on a kind of a reefer madness, sort of
Right.
like this is a scare thing.
Sure.
I think that's part one. Part two is, because it's been illegal, the research is terrible.
Exactly.
And even I was reading articles on the whole issue of psychosis and the relationship with that. And there have been a couple studies looking at sort of early markers of schizophrenia in people like pre-schizophrenia. And clearly, there was one study that showed that people who have those markers are more likely to smoke marijuana.
Exactly.
So you don't know if they're
Right.
like self-medicating symptoms that they don't understand.
Yeah.
So I think as the medical community and from a public health point of view, we have to be really careful about the message we put out.
Absolutely.
Because either one, we'll just have people just not tell us anything,
Right.
or we'll actually be giving people kind of a false information. So I actually think it's a really good thing that we've legalized it, and hopefully at a bigger level, people will actually start to do legitimate studies on things like neuropathic pain,
Right.
MS. Because otherwise, people will just do it on their own. They'll do their N-of-1 studies.
That's right. Yeah. So I think the important point there being, don't alienate your patients in terms of that therapeutic relationship. Recognize that we may get a lot more information now that we have legalization and we have pure samples, pure supplies that people are being given, and that may lead to more therapeutic effects. We don't really know, and coming across as knowing everything or thinking that we know everything is not the right way to go.
People up for drug use is probably way more damaging than
Totally agree.
any kind of
Yeah.
thing they would smoke.
Yeah. Yeah, Louise.
I'm curious if this and some of your other research helps you conceptualize quantification of use. Because I feel like right now when I talk to a patient, it's more dichotomous, like yes or no,
Right.
where I have no idea
Right.
what that means. So do you have a better conceptualization of this is mild, moderate, heavy, or?
So the question is, how do we really quantify how much they're using? I mean, we can tell based on the number of grams that they're given, if they're given it from a medical marijuana perspective, they may have some idea of how many grams they're using on a regular basis, but how do we as clinicians think about the quantity that they're using and whether or not that may lead to some of these side effects? And I think it's a really good question. I think in terms of knowing how often they use and what they use it for is the main way that I try and perceive that. So you've got a lot of patients. In fact, I've had a couple veterans come up to me and say, look, we're using this as a population to get off of opioids now. This is our trial, is to try and do that. And those patients, or the people who are trying to replace something else, are using it very frequently because they're really experiencing those cravings and those withdrawal symptoms, and they're trying to treat that with marijuana. So having some idea about why they're using it and what they're trying to fix or what they're trying to treat can help you know how frequently and how often. Obviously, you can ask them, and that doesn't always get at the specific content or the concentration or how much, but having some idea about how frequent and what they're trying to treat are really the big things I would look for. Yeah, Dave.
Well, you've given us, I think, dozens of reasons why marijuana and its constituents should be treated as a drug. And if so, we're missing, and I'm not arguing with Ruben at all in terms of his social, moral, blah, blah, blah.
Sure.
But anyway, the FDA would love to get their hands on this.
Yes.
So are any, and as far as Louise's comment, we don't even have valid serum concentrations. We don't have legalized dispensaries that tell us what concentration of active ingredients are in the edibles versus the smokables versus this, that, and the other. At least with alcohol, you know how much alcohol you're getting. If you're stopped in a traffic accident, you can measure blood alcohol. My understanding is we can't even measure marijuana because of all of the various constituents and so forth.
Yeah.
So is there any advocacy going on to lobby with our legislators to allow the FDA to treat marijuana as a drug? I think that would be a powerful stimulus for appropriate research activity.
Yeah, so the point being, really we've got enough physiologic data to suggest that this could be an effective therapeutic target, not to mention a good thing to study to better understand what the adverse effects are. And there's no question there's a massive lobbying representation that has tried to get this taken off of the Schedule I designation. And the recent reaction publicly in terms of what that's led to, so them saying again that it is a Schedule I drug and thus cannot be clearly regulated or researched as much as we would like, has been very disheartening. I think a lot of the public has been frustrated with that. I know that they're going to continue to look at it, and the more areas that legalize it, the more pressure there will be to do that. But I think you're absolutely right. There's a lot of benefit that can be gleaned from this, and there's a lot of knowledge we have yet to acquire, and moving it in that status would help quite a bit. Yeah, right here.
What's the prevalence of marijuana use in physicians, number one, and how did that affect their practice of medicine?
So the question is, what is the prevalence of marijuana use in physicians, and how might that affect their practice? I have no idea. I think it's an important question, absolutely. I think, you can imagine if someone is acutely using, again, you have to think about that motor vehicle accident correlation. There's some sort of a cognitive effect that you don't want your surgeon to have, right? That being said, I think it's still early for us to know that prevalence. I don't know. It's a great question. I would suspect it's probably a little bit below the average population. So I suspect it's, a low prevalence relative to the population, but that's a guess. I mean, who knows?
Maybe high. Yeah, we have a stigma about marijuana, but we know a lot of physicians are alcoholic and have practiced, and
Yeah.
been non-disciplined, and there are lots of issues that are just now coming to focus, so it's not much different from that.
Right. Yeah. Amy?
Craig, I was very interested to hear about the relationship with neuropathic pain, because I've had 2 patients now who have used marijuana creams or ointments for post-herpetic neuralgia. I'm just wondering if you've run across any information about the creams or ointments.
I've seen that. So the question is, what about creams or ointments for neuropathic pain, especially in her case with patients with post-herpetic neuralgia? I certainly have seen the same thing in the patients I've talked to. And there's, again, looking at Colorado's movement to be more regulatory around edibles, but still preserve lozenges and ointments and creams as a therapeutic option, is supportive of that. I think that there's still a lot for us to know about what concentration matters, what dose matters, what conditions really benefit from this. I'd be interested to know from you whether your patients found that beneficial or not.
We went through the whole gabapentin and all the usual
Yeah.
stuff, and then actually sort of on the cuff where someone said, well, try this cream or ointment, and it's taking care of their post-herpetic neuralgia.
That's fascinating. I do
Yeah.
think the data is much more supportive for neuropathic pain than other pain. Yeah, Rick.
The cannabinoid hyperemesis syndrome, what association, if any, is there between acute ingestion and the symptoms?
Yeah, so the question is, with cannabinoid hyperemesis syndrome, is there an association between acute ingestion and the development of symptoms? And it doesn't appear to be the case. I would suspect that if there was a really close correlation, for example, you use marijuana and then immediately get the symptoms, it would be more negative feedback and patients would be more likely to stop using, or they would see that correlation more clearly. But I don't think there's, I don't know for sure exactly what the acute correlation is, but I'd be surprised if there is one. Yeah, back in the corner.
Products in the body,
Yeah, so the question is, do we know the half-life of THC, cannabinol, cannabidiol? I'm sure we've got some idea based on animal studies. I don't know off the top of my head what the half-life is, but I'm sure there is some pharmacokinetic data that we can pull off the internet. Yeah, right here.
Basic question. These oils that I see all the time being advertised, this is different than the dabbing
Yes.
oils, or this? Can you talk a little bit about the oils, because I don't even understand how they're consumed or what they
Yeah,
are.
so the question is, what do we think about the oils that are marketed as, again, oils or tinctures or those kinds of things compared to these oils that are really potent? So butane hash oil is the very specific kind of oil that's dangerous, and that's the kind of highly concentrated oil that you want to make sure your patient isn't using or is aware of the side effects and the consequences of that. It's the population or the preparations that are more therapeutic are simply a oil mixture of some of these chemical components, cannabinol, cannabidiol, and THC, that can have some therapeutic benefit that are completely different. So the concentration is different. Well, some of them are topical, some of them are consumed, are ingested. I think you can use oil preparations, some oil preparations in some of the e-cigarettes, but I think that the butane hash oil is really the thing you want to make sure they're not using. No, not that I'm aware of.
What, if any, is the correlation between teenagers who are starting to use this and the predilection for worse drugs, if you like?
As a gateway drug,
Yes.
sort of gateway drug hypothesis. So the question is, what is the predilection between, or what is the correlation between marijuana use and leading to other drugs? So we do have some biologic plausibility for the gateway theory, suggesting that there is a effect for patients who use marijuana, a priming effect essentially that can lead to those pathways being more utilized, and then some chronic disinhibition related to that. There's also the thought that the CNS effects can lead to changes in the fibers, so you have less dopamine, and that can then influence you pursuing drugs that can replete your dopamine or cause your dopamine to be distributed into the synapse more quickly. And then there's also the effect that those patients who are using a drug like marijuana on such a frequent basis could have cravings. And the anxiety associated with cravings can certainly be pathologic that leads to the use of other drugs in a similar way.